Hi, I'm Professor Kevin Antoine. Welcome to Health Center. Today we have as our distinguished guest Dr. Wayne Duffus from the Center for Disease Control and Prevention down in Atlanta, Georgia. Dr. Duffus, welcome to the show.
Thank you. Nice to be here.
So let me start out just by asking you about yourself, your personal background, where you're from, where you went to medical school, how you ended up at the Center for Disease Control.
Okay, so I had a long path. I attended Brooklyn College. From there, the Albert Einstein.
From Brooklyn?
Yes, yes, biology major.
Brooklyn.
Then I did my MD PhD degree at the Albert Einstein College of Medicine, and then a residency in internal medicine at Columbia Presbyterian Medical Center. And then I left New York to Atlanta, where I did an infectious disease fellowship at Emory University School of Medicine. And after that, more punishment, I went to the Centers for Disease Control and did an epidemic intelligence service officer training program where I learned public health. And I was stationed in South Carolina for 2 years, and the state asked me to stay on, and I served as the medical director there for 10 years. And I had a joint appointment where I was at the health department as well as at the University of South Carolina School of Medicine, where I was an ID infectious disease provider in the Ryan White HIV clinic. And after 10 years, I came back to Atlanta to be at the CDC.
So South Carolina, tell me about some of the work that you did there and how that work played a part or role in getting you to do the same or similar work at the CDC.
Yeah, so that was quite a highlight of my career. You know, for the clinical component, which I spent 30% of my time in the HIV clinic, we have about 2,000 patients there. And one of the things with working with patients is that the problem is right there and you have a name that goes along with it. So when we make decisions at the state government level and now the federal government level, I know the consequences immediately. So it's really a way of bringing you back home and tell you how effective your policy research and programs are working. And then at the health department, I was the state medical director in the HIV, STD, hepatitis division, and I did research, policy program, I did education. I trained the nurses and social workers on proper management for HIV and STDs as part of the Southeast AIDS Education Training Center. That was wonderful. We worked in collaboration with the School of Public Health, where I had students who were doing their master's, MPH, Master's of Public Health, and their PhD degree would work with us at the health department for their research projects. I was also the medical director for the AIDS Drug Assistance Program Pharmacy, and when we had our wait list, we actually had two. We had to decide who gets meds and who doesn't, and who wants to be in that position. And we had to educate the community to do advocacy work to get us more funding. And that was quite a learning experience for me, because as a doctor, you want to save everyone, but with limited resources, some get and some don't. But fortunately, through our partners, the pharmaceutical companies, we're able to step up so that no patient went without getting medicines. So that really prepared me to move over to the federal government, because then I recognized that even at the 35,000 feet level, there is a person out there that your decisions will have some impact on, a name and a face that goes along with it.
So now tell me a little bit about the work that you're currently doing now with the Center for Disease Control and Prevention.
Okay, so currently I am the Associate Director in the Office of Health Equity in the National Center for HIV, Viral Hepatitis, STD, and TB Prevention, NCHH-STP. It's a lot of acronyms, but it shortens it. And so my center has 5 divisions: Division of Adolescent School Health, Division of TB Elimination, Division of STD Prevention, Division of Viral Hepatitis, and Division of HIV/AIDS Prevention. So my office is the Office of Health Equities at the center level. 2 of the divisions also have offices of health equity. All 5 divisions contribute members to a health equity work group, and we meet monthly, and primarily information sharing about policy, research, and programs that occur in our center that addresses health disparities. And so whenever research, policy, and programs are being developed, these members can contribute the ideas as far as what's important and how to go about addressing the social determinants of health. And it's been wonderful work. We have additional work groups, so corrections, for example, or women's health, or young adults, and so on, that occur monthly or at different frequencies.
So tell me a little bit about the work that your office does with respect to working with the levels for different state agencies or city agencies. What sort of resources do you provide?
And so, the center tries to foster collaboration within the divisions, also with the state government. We work primarily with health departments. The Division of Adolescent and School Health is the exception because they work primarily with the Department of Education.
Okay.
We don't have regulatory powers. We try to provide the science to justify why we should take action. So that's where our surveillance comes in and our research. All problems are local, so it's hard to have a one thing fits all. We leave it up to the local state jurisdiction to determine how the priorities should be. But we have had consultations where we bring in our partners to come in and share their ideas with us as far as what's important, how they think we can benefit or we can help them benefit from our resources. So we try to be as collaborative as much as possible.
When you look at the populations, whether they're urban or whether they're rural, do you see the same rate of infection with respect to various infectious diseases, or do they vary based upon population, whether urban or rural, or is it a mirror image across the board?
So it varies. So it all depends on the disease. So for tuberculosis, for example, we're done quite well, close to eliminating tuberculosis or TB. The problem now is concentrated in homeless and in foreign-born population.
Okay.
For HIV, it's young men who have sex with men, young MSM, particularly MSM of color.
Okay.
For sexually transmitted disease, it's a disease of youth, 24 and under. But we find that there's some disparities there. So even for gonorrhea, primarily about 70% African American.
Okay.
Right. So there are disparities. There are also geographic differences. The majority of cases for HIV are in the South, which are resource limited. Right. Disparity in age, STDs, HIV, young individuals. Right. Socioeconomic status, mostly poor people. Right. So there are differences and more concentrated in urban settings. Even though the South and the rural areas have a lot of cases, they're spread out. Right. So when we design our cooperative agreements, we have to take those things into consideration as well.
So I heard you mention health disparities. What would be some of the essential elements of a health disparities program that the CDC considers essential if they were going to give some resources to that particular jurisdiction?
So any health disparity program should be science-based. Science is going to inform us and tell us the direction in which we should go. There also has to be a good surveillance system as well. So we have multiple surveillance systems at CDC, and my office and the Health Equity Work Group has worked in collaboration with the surveillance work group to make sure that we're collecting the right variables, collecting the right information. You can't say housing is important and you're not asking about housing status.
Correct.
You can't say, food and nutrition is important and you're not asking about that. You got to ask about employment status. So we've done an evaluation of the surveillance system. Well, when I say we, the Office of Health Equity, and we have published in the public health reports about an evaluation of our surveillance systems and the ones that collect a lot of social determinants of health variable. We can use that information to improve our surveillance systems. I try to meet frequently with the various division directors and ask them, do you talk to your staff about health disparities and addressing social determinants of health? So when cooperative agreements are designed, is that an aspect of it as well? All funding opportunity announcements in our center ask the respondents to talk about how they're going to address social determinants of health. And that's a requirement as part of the FOA. Later on, we're going to ask the respondents we're going to develop metrics and ask the respondents, well, now that you've had the money, 2, 3, 4, 5 years later, the desired outcome, have you not only decreased the rate, but have you also narrowed the gap, the differences between populations? And so those are essential components of the program that have been done and that are also in progress.
You talked about the social determinants of health. I remember when I was back as a fellow at the School of Public Health at Harvard at the beginning of the decade, that language was just starting to enter the public health language here in the United States. What role does the social determinants of health play in combating infectious disease or controlling infectious disease?
Extremely important. So the social determinants of health are those life-enhancing resources that are necessary for good health outcomes. So the determinants of health starts off with the genetics and biology. Example would be race, ethnicity, or male, female. We spend a lot of time talking about black-white differences, but those things can't be changed. You can't change your skin color, right? Those are non-modifiable. The next step is the individual, so behaviors. So alcoholism, substance use, injection drugs, smoking. Some of those things are genetics and some of it is lifestyle. Then there's the physical environment, so where you live. Then there's a social environment, networks. Who do you have sex with? Who do you play with? And then there's healthcare, so access to healthcare and affordability. So the physical environment, the water to drink in Flint would be part of the physical environment, transportation, the social environment, and health services. Those three would constitute the social determinants of health. Now, regarding sexually transmitted diseases and HIV, how the social determinants of health become important. If you live in a neighborhood where there's a high prevalence of a disease, that even when you're trying to be a good person and do everything that you're supposed to do, the opportunity to encounter someone who's infected increases dramatically, right? The pool from which you're selecting from increases dramatically. We have done a lot at CDC by promoting expanded HIV testing and make testing become routine. We're trying to expand testing for hepatitis C for the baby boomer population because we think knowledge is power. Once you know your status, you protect yourself and you protect your partner. And if you're infected and you get on medications, then you lower your viral load, which is the amount of virus in your body, you decrease transmissibility. If you test negative, we try to develop your understanding and knowledge of what it means to be negative and provide you with the resources and information, as well as condoms, knowledge about HIV pre-exposure prophylaxis, where you take a pill once a day to prevent you from acquiring HIV. So all of those working together help us address the sexually transmitted diseases of our center.
Do you see a difference in the infection rate when you're comparing it by gender, male versus female, with respect to the infectious diseases that come under your area?
Yeah, so for HIV, for example, it's more common in men, and mostly men who have sex with men. For women, it's more common in the prevalence. I should say it's mostly noted in African American women. But I try very much to stay away from color and gender. One of the underlying things, if you look at socioeconomic status, it takes away race, ethnicity.
Sure.
It's a problem of poor people. Poverty is the problem. There's no difference between black and white based on our skin color. It's poverty. And so my office is trying to change that conversation where we focus on the social determinants of health rather than the biology and the genetics. Because I think, considering the history of our country, it becomes a very difficult conversation to have with folks. And we don't want to have those conversations if we're not going to solve the problem.
Sure.
So let's look at things that we can fix and things that we can change. And we change those things by multi-sector collaboration, because 80% of the things that affect health apparently have nothing to do with health. So let's take education, for example. The more education you have, the longer you live. Let's take income. The more money you have, the longer you live. If you have good housing, the longer you live, right?
Right.
And so if you fix those things, then you have better health outcomes. Now, individuals can't fix those things. That's where government becomes important. And so the various government agencies at the federal level and state and local have to work in concert to bring about improvement in people's lives.
So what you're saying is that there has to be more of a collaborative effort between not just the different levels of government, but government in and of itself and some, I guess, aspects of the private sector have to be part of this coalition to address these public health concerns.
Yes. So private sector, because government doesn't create jobs
Correct.
in a way in which we want them to. So public-private partnerships are really, really important. And for CDC, we try to provide the science and evidence for why that's important, and to have a presence at the table where we can spur the discussion as to the necessity and importance of those things.
So talk about some of the international aspects of what you do. I know you shared with me recently that you had a trip to India where you had to engage in some work.
So there's a Center for Global Health that does a lot of international work, and certainly my center does some. So one of the good things about working with the federal government, at least at CDC, is the opportunities to do temporary assignments. We call them detail. So I was in India in the HIV care support and treatment branch with Dr. Pauline Harvey as my supervisor. And India is a great country. I think of India as not a poor country, it's just a country with a lot of poor people. There's a lot of resources, beautiful country, beautiful people. But I was struck by the similarities sometimes between a resource limited setting and the United States, which is resource plenty.
Okay.
And how
explain that?
Well, I visited a TB clinic, a tuberculosis clinic, and one of the things that we noted was the absence of respirators and masks. And we thought, well, respirators that you put over your face to prevent you contracting TB, it's common.
Right.
And we said, all the staff, when some of the patients, they're coughing, they should have masks on. And they go, sure, we see 5,000 patients in one day. So even if they cost $2, you multiply it by 5,000 per day by a year, you realize it's impossible when your budget is limited. Then here we are now in South Carolina, where I was a state medical director, and then we had a wait list to get patients on HIV medications. And we can afford it in America, but for whatever reasons, we were not able to. So you find the questions I was asking in India about affordability and access are the same questions I could ask in rural America.
Sure, okay.
And you realize just how similar and how some problems occur. And not just among African Americans. If you look at white America and Appalachia, poor people get the same diseases and have the same outcomes, and it's the social determinants of health. Now in the rest of the world, when they look at problems, it's income disparity, the haves and the have-nots, the SES. In America, it's black and white. We look at the problems differently.
We look at them differently. So do you think here in America that we might at some point catch up with the rest of the world and start looking at these various infectious diseases as how they just affect people based upon the social determinants rather than race?
So I'm an optimist, and America is a great country. I look at me as an immigrant from Jamaica, and here I am, a doctor at the CDC, right? So I'm very hopeful. America is a great country. I look at the Affordable Care Act, which is all about social determinants of health and access to medical services. That's a great step forward. We've had other programs, Medicaid, Medicare, Social Security.
Sure.
I think that we're moving forward. I wish we could do it quicker, better, do more, do better. But I'm optimistic, and I think there are examples of where we've done well, but we have so much further to go. But it takes public-private partnerships. It takes collaboration within the federal government and collaboration with the state and local and tribal entities to get it done. And we all need to be on the same page and realizing that at the end of the day, it's the United States citizen that benefits. And that focus is important.
You talked about the Affordable Care Act briefly. Can you tell me what are some of the things that have been beneficial with the passage of the Affordable Care Act? I know there are some sections of the country, depending on where you are, it's either the worst thing that's ever happened in healthcare or it's among some of the better things that has happened in healthcare. Is there any aspects of the Affordable Care Act that have been essential or at least helped in the work that you guys do at the CDC?
Well, we recognize that the Affordable Care Act is not a cure-all, and this is just speaking in general. Being in public health, anything that affords access to care,
Sure.
even though it's not the only thing that's needed, but anything that affords access to care, for us, we see that as a positive. The implementations are occurring at the state level and not with us at CDC. And so, whatever we can do to encourage that, and the states that are non-implementing have been very ingenious at coming up with ways of getting patients care somehow. But overall, I think it's anything that increases access to care is a good thing. If we think of where we're coming from, and certainly we want citizens of America to have access to HIV testing, hepatitis C testing, to STD screening. And so there's no way I could say it's not a good thing. It's not that.
What are some of the challenges that you see ahead in the work that you do?
I think some of the challenges, one would be workforce development. I think the graying of the population, that an individual is more likely to go back to an era where they're from. And so we need to recruit and maintain and mentor individuals from resource poor setting in the hopes that they'll go back. And the studies show that they will go back and work in their area. I find a lot of times in these areas there are good programs, but they're centered around individuals.
Right.
And once that individual leaves, the program falls apart.
Right.
And so we need to think about sustainability, right? What happens after that person leaves? Not the person, it's the program. Sustainable programs, that's quite a challenge. Another difficulty I think we have is translational science, translational research. So we do the bench work and we know it works, but how does it work in a real world setting? We need to be able to translate that. And because we're successful at doing it, or because New York is great at doing it, doesn't mean Alabama is going to be great at doing it, or Mississippi or California. Populations are different, resources are different. Intersectionality, where we try to think of the individual as that person with HIV or that person STD. Well, people have multiple problems. They have STD, they have mental health problems, they have substance abuse, and oh, by the way, they're hungry and they live nowhere. How do all those work together to bring about poor health outcomes? I think our surveillance system has to improve. What gets measured gets fixed. And if you're not collecting it, then you can't address the problem. We really need to improve our surveillance system, which we are working on. Slow,
right,
but we need to pick that speed up. Another thing for me I find is communication. Technology has changed so much. And in the federal government, where we always want to make sure we're accurate and we're certain and we read things over 20 times and 50 people sign off on it. In the 24-hour news cycle, the problem is over before we can even come up with a solution. So we need to find different ways of communicating with the population in a timely sense, in particular for a younger generation that responds better to tweets and Twitter and all of that as opposed to long peer-reviewed publications. I think that's going to be a challenge for us in the future, if it's not already here.
Tell me very briefly, where do you think that we will be maybe in 5 years with respect to reducing the infection rate with some of these infectious diseases that your office is in charge with of controlling and preventing?
So we've done very well with tuberculosis. Like I said, the problem now is with homeless and with foreign-born populations. And so the Division of TB Elimination had a consultation where they brought in stakeholders to talk about how we're going to go about addressing that. And so stay tuned. The last 100 miles tends to be the hardest. To be the hardest journey. But we're close for tuberculosis. For HIV, we've had a lot of success. In my early training in the 80s, I remember just how horrific it was, where there was no medicine, to now where people think HIV is not a problem anymore. And it's a double-edged sword because it still is a problem,
right,
but it's a controlled problem for people who have access to care. The only population that we're having challenges with is with young men who have sex with men, particularly young MSM of color, right? What's new now is HIV pre-exposure prophylaxis, or PrEP, where someone who's HIV negative would take that medicine daily to prevent them from acquiring HIV infection. So in addition to all the other tools that we have for folks who are negative, PrEP opens up a new avenue of intervention. So there is PrEP for the individual who's HIV negative that prevents them from acquiring HIV. Combine that with access to antiretroviral treatment, which allows you to keep your viral load, the amount of virus in your body, undetectable, which decreases transmission in heterosexual couples by 96%. When you combine those two things together, I think in the future, we should start seeing big differences for that population. For sexually transmitted diseases, still a struggle. In fact, there's a consultation going on right now as we speak in Atlanta about syphilis elimination. So there's still areas there to change. And then the Division of Adolescent School Health is trying to work with the Board of Health, the Board of Education, to talk about what sort of curricula are important to address at that age group, the young adolescents. So slow progress, but we are definitely making some changes.
Good. Well,
Yeah.
Dr. Duffus, I want to thank you for being our guest
Yes.
upon Health Center, all the
Yes.
valuable information
Yes.
that you informed us with.
Yeah.
And remember, we do have an office in the federal government that is charged with preventing and controlling the spread of infectious disease. That's the Center for Disease Control. And remember, they're on your side. This is Professor Kevin Antoine with Health Center.